All right, let's dive into the critical differences in pediatric trauma care. We're going to focus specifically on you, the surgical assistant, because your role is absolutely key to saving our smallest patients. But before we get into the mechanics of it all, I want you to really understand the stakes here. The impact of a serious injury on a child and their family. It goes so much further than what we see in the trauma bay. We're not just saving a life in that moment. We're trying to preserve a whole future.
So we're going to follow the ATLS framework that you already know and love, but we'll be highlighting exactly where pediatric care takes a sharp turn. We'll start with the most important core principle, then cover the unique challenges in airway and circulation, and wrap up with the vital topic of non-accidental trauma.
Okay, this is it. If you remember literally one thing from this whole explainer, make it this. Children are not just scaled-down adults. You can't just use smaller equipment and call it a day. Applying adult standards and adult expectations can lead to missed signs and, tragically, delayed care. Here's the deal. Their physiology is practically designed to hide big problems. Kids have this incredible, almost unbelievable ability to compensate for blood loss and shock. They can keep their blood pressure looking pretty normal until they are right on the edge of a cliff. So your assessment has to be tuned to catch those tiny, subtle clues of compensation before they go over the edge. So let's move to the A and B of our primary survey and see how this all builds. You see, a child's airway isn't just a tinier version of an adult's. Its whole geometry is different, and that presents a totally unique set of challenges. Now, check this out, because this is really interesting. Every single one of these differences has a direct, practical implication for what we do. That larger occiput, for example, well, it forces a child's neck to bend forward when they're lying flat, which can actually pinch off their airway. And that larger tongue and higher larynx, it makes getting a good view for intubation way more difficult. So how do we adapt? We get ahead of it. We anticipate. As an assistant, having that padding ready to go under the shoulders and torso to get the head in that perfect sniffing position is huge. Knowing that a straight blade might be needed, and understanding why a shorter trachea means we have to be super careful about tube depth. These are the kinds of things that make the whole process smoother and a heck of a lot safer. And this is a perfect example of another key difference. In an adult, a big lung injury usually comes with a bunch of broken ribs, right? But in a child, their chest wall is so flexible, it can take a massive impact, transfer all that energy straight to the lung to cause a serious contusion, and then just spring back with no fractures at all. The outside signs completely hide how bad the injury is on the inside. Okay, on to C for circulation. And this is where pediatric patients are absolute master illusionists. It's where your sharpest observation skills are critical to see through the act. So let me ask you, in adult trauma, a dropping blood pressure is a huge red flag, right? Is it the same for kids? What's the very first thing that tells you a child is in real trouble? Yeah, that's right. The answer is not a drop in blood pressure. If you're waiting for a child to become hypotensive, you've already missed the most critical window to act. You are way, way behind the curve. And here's why that's so scary. A child can lose up to 30%, 30%, of their circulating blood volume before their systolic blood pressure even starts to drop. Their body's ability to compensate with intense vasoconstriction and a faster heart rate, it's just that powerful. So the key is you have to be hunting for these earlier, more subtle signs. Tachycardia, a fast heart rate, that's often the very first clue. As an assistant, you're in a unique position to just watch. Being the one who speaks up and says, hey, this heart rate isn't coming down, or their feet feel cool and their pulses are weaker, that is a life-saving intervention. Okay, moving right along to D and E, disability and exposure. Now, the basic principles are the same as in adults, but for children, the risks are just magnified, dramatically. To put it simply, kids are just really inefficient at staying warm. They have this huge amount of skin surface area compared to their small body mass, and it acts like a giant radiator. They just pour heat out into the environment incredibly fast, which makes hypothermia a constant major threat. This means these actions aren't just for comfort, they are absolutely critical resuscitation steps. And this is an area where you, as an assistant, can really take charge, making sure the room is warm, that fluids are running through a warmer, that blankets are ready to go. This is how you help prevent that lethal triad: hypothermia, acidosis, and coagulopathy, where the blood just can't clot anymore.
And finally, we have to talk about something that's difficult, but is absolutely vital. As a member of the trauma team, it is part of your job to be alert to the possibility that an injury was not an accident. The statistics here are truly sobering. A child who has been physically abused has a 6 times higher mortality rate than a child with an unintentional injury. What that means is that keeping a high index of suspicion isn't just good practice. It's essential to protect our most vulnerable patients, especially those under 2 years old. These are the kind of objective findings that should be major red flags. I want you to remember that phrase: if you can't cruise, you can't bruise. A baby who can't move around on their own shouldn't have bruises, period. Part of your professional responsibility is to empower yourself to speak up when the story you're hearing just doesn't line up with the injuries you're seeing. So look, if you take just one single thing away from this whole explainer, let it be this. A child's body is built to hide how sick it is. They will compensate and look stable right up until the moment they completely crash. Your job, our job, is to be the one who sees through that compensation and helps the team intervene before that crash ever happens. So that's our look at adapting ATLS for pediatric trauma. And it leaves us with a question for you. How are you going to use your unique observations to be the strongest possible advocate for your next pediatric patient? Stay sharp, stay vigilant, and always, always remember, they are not little adults.